When you do that, Jean-Luc. So Jean-Luc is now back with us, and it gives me great pleasure to hand over to him. I've given him a great build-up. Who better to talk to us about the view from the patient community than the CEO of the World Health Federation?
Thank you very much, Sarah, and welcome everyone.
Okay, Jean-Luc, you are off mute, but we still can't hear you, I'm afraid. Can you unmute yourself?
Is it better now?
Can you hear him?
Yes.
No, I'm afraid we are still not hearing you, Jean-Luc.
Yeah. On the screen,
I can hear him.
Everybody else can hear him. Okay. All right. My apologies.
Welcome, everyone. Let me start with the question first. I cannot move to the next slide either. So if you can do it for me, please. Let's start with the short question. Can you? Anyway, you can go back. Thank you very much. Let me start with a short question. It's a survey which was done by the International Diabetes Federation a few years ago, asking patients about their cardiovascular risk. And the question that was asked is, how many of the respondents never discussed cardiovascular risk or couldn't remember discussing this with a doctor? So I think you will have the option to answer the survey. So 5, 10, 25 or 30%. So if we can have the results. Okay, from what I've, so it's not too bad. The actual answer is 25%. So 1 in 4 thought they never discussed cardiovascular risk with their physician. Thank you very much. And there was actually a lot of interesting data in this survey. If you look at the population which was surveyed, 9 in 10 had 1 or more CVD risk factors. 1 in 5 had experienced a CVD event, including heart attack, heart failure, stroke. In terms of awareness, 1 in 10 did not know about CVD and its associated risk factors. 1 in 4 considered themselves to be at no or low risk for CVD. And in terms of relationship with the doctors, or as we just said, only 1 in 4 discussed their CVD risk with a health professional. 2 in 5 considered that they would not increase their CVD risk as long as they took their medication. So a lot of interesting data. Let me start now. If I can have the next slide. So to the detectation, I'm assuming you're moving the slides. Next one, please. Let me start with the patient story. And I'm going to use 2 different stories, and I think it's worth to listen what the patient said. So I'm going to actually read it to you with their own words. So the first one is Werner. Werner is living in Germany. He's 60 years old, and he's saying, 20 years ago, I was diagnosed with type 2 diabetes and was told that I would have to follow precautions and carefully look after my health. I was a happily married, retired bookmaker with 3 children and 5 grandchildren. Other than having diabetes, I felt fit, happy, and healthy. After picking up a leaflet at my doctor's surgery, I decided to have my heart checked. My test revealed a possible problem. I was sent for angiogram, which showed 5 blockages, 3 in the main arteries to the heart and 2 minor blockages. I was told that the problem was serious and I needed surgery. Just a few months later, I was recovering from triple bypass surgery. I'm grateful that my problem was picked up before I had symptoms and it became life-threatening. I hope my story will encourage people to monitor their heart health to avoid potentially serious problems especially for people with diabetes, and they often fall into a higher risk category for developing heart disease. I was not aware of this increased risk until I was diagnosed with heart disease 1 year ago. So it's a kind of very typical story of someone who is suffering from diabetes and by accident was checked for heart disease and was properly managed and is now happy. Let me look at another case, which is the lady you find on the street, Anne Darling. She's living in the US. And she started by saying, "It's a miracle that I'm here and feeling so well. In 2001, while I was at work, I had a mild heart attack. They kept me in the hospital for a few days and placed 2 stents in my heart. A few years later, I started to experience problems with my eyes, and when I went to my doctor, they asked if I had diabetes. They tested me and found out that I was pre-diabetic. After my heart attack, a dietitian had recommended that I ate around 45 grams of carbohydrates at every meal, but it turns out that this accelerated my diabetes." At this point, I knew nothing about the link between heart disease and diabetes. I only found out about it 4 years ago through my own research, and I discussed the connection between health issues with my cardiologist. This knowledge has made a huge difference to me, particularly as around the same time I found out that I had the early stage of kidney disease. Diabetes affects the heart, the kidneys, everything, they're all connected, she says. Now I feel amazingly well, but it's taken a long time to get here. In January, I had a kidney transplant, thanks to my son donating one of these kidneys. I took part in a SAPAS program which helped teach me how to cook for people with diabetes and was actually a big part in totally changing my eating patterns and has made the biggest difference to me. In my last blood test, my cardiologist was thrilled as every reading was within the normal range. These improvements have enabled me to reduce the medications I've been taking. For the last 5 years, I have been proud to be part of a Diabetes Sister, an organization that in half of the states in the US is growing steadily. We're a peer support group that's free for anyone with any type of diabetes. I'm happy to share my experience and help inspire people with CVD and diabetes to make those lifestyle changes that can make all the difference. For One Heart Day, that's on the 29th of September, I want to stay focused on taking care of my health and to ensure that I'm around to have a good, long, and a happy life with my family and friends. So it's another interesting case where she was diagnosed first with CVD, but it illustrates the strong links between diabetes and cardiovascular health. So if I can move to the next slide, the One Heart Federation is a number-one organization that has about 200 members, cardiologists, professional societies, foundations, and patient groups. We are very happy to have a strong connection with the World Health Organization. We are so-called official relationships to give us some kind of privileged access to Dr. Tedros' office when he's not busy with other topics. Next slide. Our mission and vision is that heart health is a fundamental human right and is essential for global justice. And we have 3 missions: connect and convene the cardiovascular community, and we do this through membership through World Heart Day that we are organizing every year on the 29th of September. Translate science into policy, and I think in the case of CVD and diabetes, we'll come to a practical example. And finally, catalyze and stimulate the exchange of knowledge among professionals, patients, and the general public. Next slide. Just a few numbers to remind you. I think Ricardo said we have 2 pandemics. I think that's the first one, the cardiovascular pandemics. As you might know, that's the largest killer, almost 18 million people every year, 31% of all death. And it's not only the elderly. If you take the age 30 to 70, it's still 10% of the people that who will die from cardiovascular disease. And on the next slide, the second pandemic, that's the diabetes. If I can have the next slide, please. Yeah. So as it was said, type 2 diabetes is a major global health threat. It's affecting every 1 in 11 adults worldwide, 425 million people, and accounting for approximately 90% of all patients with diabetes. It is also a rising threat. Cases doubled between 1990 and 2016, and the total number of people with diabetes is predicted to increase to 629 million by 2045. Those living with diabetes 2 are 2 to 3 times as likely to experience major stroke subtypes, coronary heart disease, myocardial infarction, sudden death than patients without diabetes. So that these two pandemics which are combined. If I can have the next slide, please. WHF did a survey to our members in 62 countries. You see them in red. And it was really widespread of developed countries, and developing countries, and low-income countries. And on the next slide, you see the results of this survey. So 61% of respondents do not have community hospital programs on the risk of CVD. 29% do not have relevant clinical guidelines or protocols for detections. 25% do not have follow-up treatments. 57% do not have standardized screening. 71% have a waiting time over 1 month to see a specialist in the public health system, and it's not only developing countries, as we know. And 44 responded that they do not have access to healthcare facilities. So, if you look at the studies, they consistently highlight that the perspective of patients and healthcare professionals are not aligned. Differences in perspectives between patients and the healthcare professionals may have an impact on patient care. Interestingly, patient benefits are reported when healthcare providers consider challenges from multiple perspectives. A patient-centered approach to care requires an improved understanding and appreciation of the daily challenges faced by patients and caregivers, dedicated funding, and well-designed health systems that meet the specific needs of these patients. Opening the door to this perspective, the ideal patient care pathway is populated with viewpoints of those living with type 2 diabetes to offer a better understanding of the intricate parts of care pathway and what this means to the patient. And we will spend quite some time on this slide. So this ideal pathway of care is grounded in prevention. First of all, prevention of obesity, metabolic syndrome, and type 2 diabetes among the general population. Secondly, prevention and early detection of type 2 diabetes among cardiovascular patients. And essentially, thirdly, prevention of cardiovascular disease among people living with diabetes. So if I tackle maybe the first issue, low awareness. Within the survey that had been sent by WHF and IDF, what was quite likely is a lack of patient awareness of the risk of CVD. This was ranked by 95% of the respondents agreeing or strongly agreeing across both surveys. By increasing global understanding of the link between CVD and diabetes, there is the hope that we can reduce the incidence of CVD through patient engagement and behavior change. This will represent the first step in reducing the burden of diabetes, simultaneously, of course, helping people with the disease to control their diabetes. Awareness campaigns focus on making the link between CVD and type 2 diabetes are the first step to better general public understanding and appreciation of this growing burden and the actionable steps that can be taken to reduce it. And at the end of my presentation, I will come back to a new exciting initiative that WHF is launching. CVD and type 2 diabetes are linked with poor diet, lack of physical activity, smoking, and obesity among lower socioeconomic classes, a trend widely reported at the global level. Therefore, the public must be made aware of the benefits of healthy lifestyles, but these choices must be made accessible and affordable. So it's not only an individual decision, it's also the system that should make these choices easy. Talking about prevention, strategies for people living with type 2 diabetes focus on CVD prevention, so from the lifestyle management, including heart-healthy diet, regular exercise, smoking cessation, and risk factor interventions, as was mentioned by Ricardo, including lowering blood pressure, lowering low-density lipoprotein cholesterol, controlling glycemia, and taking heart protective medications as prescribed. It is also important to note the unprecedented link between obesity and the development of onset type 2 diabetes, with report of as many as 90% of people with diabetes being overweight or obese, making this risk factor indirectly responsible for a consequential upward trend in CVD for this growing percentage of our global population and community. Moving and talking about screening, a coronary event is often the first time type 2 diabetes is recognized, as for in the story of Anna, and therefore screening for dyslipidemia is important in at-risk individuals. Screening at the level of general practice may identify those at high risk with the metabolic syndrome. A multitude of roadblocks exist around limited screening and optimal diagnosis of type 2 diabetes. There is also a need to remove all the barriers for access to healthcare, accessibility, geographic accessibility. There are very interesting cases, for instance, in the United States, where creating a bus line between one part of the city and the hospital improved access to care and reduce heart failure in that case. Acceptability, social and cultural, and the affordability, financial for the patients, and the availability of health services and resources. Typically, the limited number of diabetologists and endocrinologists providing timely diagnosis of diabetes has a direct and measurable impact on detection of cardiometabolic risk in this at-risk population. Among endocrinologists, factors preventing optimal management may include sheer numbers, given the high incidence of diabetes and very limited numbers of endocrinologists in some countries. Next point I'd like to tackle is the fragmented care and the need for multidisciplinary approach. A number of barriers to integrated care were identified in both the WHF and IDF survey, including, in quote, fragmented, episodic, and catastrophic care. 80% were in agreement with this statement. And those living where the healthcare teams fail to work together across primary, community, and specialist care setting. 93% were in agreement. Integrated care describes a partnership across a team of healthcare practitioners who work collaboratively with those living with type 2 diabetes and CVD in a coordinated effort to make decisions for the best possible health and social outcome. For screening of CVD among those living with type 2 diabetes, integrated care within the community and primary care setting is essential to the timely diagnosis of CVD. I think Sarah, as a GP, knows this very well. Within our current health systems, integrated care remains the exception rather than the rule. Perhaps most notably due to reported challenges with implementation such as insufficient integration between patient database, and I'm living in Switzerland where we still do not have an electronic healthcare record for patients, the lack of targeted remuneration or financial incentive, the lack of collaboration across settings and between professions. From the survey data, it's obvious that clinical practice based on evidence is commonly not implemented as recommended, and contrasts with the development of new pharmacological possibilities that have made a timely identification of dyslipidemia, particularly in patients with coronary heart disease. An integrated approach to healthcare delivery is not new to healthcare systems, and evidence clearly links this to improve patient outcomes. Yet, interprofessional practice remains among the greatest reported barriers to patient care. There is currently a very interesting project in the Philippines with the aim to place the patient at the very center of the organization of care. And this research project investigates two specific actions areas. First of all, the communication to investigate integration of better communication channels to share information on patients and patients' outcomes. And secondly, the education tools to support it. For this project to become a reality, an integrated approach to care is needed, including not only diabetologists and cardiologists, but also internal medicine specialists, general practitioners, alongside nurses and other caregivers. It would provide clear and targeted information about the area of cardioprotective drug regimens for patients with type 2 diabetes. Education is also among the key solutions in avoiding clinical inertia, and when I say education, it's of the healthcare professionals. Avoiding clinical inertia with recent and ongoing research proving that several anti-diabetic drugs reduce cardiovascular events and even cardiovascular and general mortality. Finally, monitoring and follow-up to ensure a successful approach to the monitoring and follow-up of those living with diabetes and CVD. A systemic approach to supporting the changes of lifestyle is essential. And as reported, there's 3 steps. Follow a healthy lifestyle, including addressing obesity and health eating, exercise, and tobacco cessation. We're repeating this, but it's really essential in the management of this disease. Self-management, including adherence to medication, and where possible, self-monitoring of glucose and blood pressure. And finally, awareness of the microvascular diabetes complications, including eye, foot, renal complications. Supporting patients to meet these health demands is not an easy feat, and it requires health system to be adaptable, flexible to individual patient needs. Strategies that work for one patient will not be the same strategy that work for others. Therefore, different options must be offered for those living with type 2 diabetes. And there's an interesting example from the Montana Diabetes Prevention Program, where participants receiving the program through telehealth have actually similar rates of participation and achieve similar weight loss as participants attending the program on site. Intensive lifestyle intervention goals can be achieved as effectively with large groups as with small groups. So there's way we can work this and explore this. Finally, let's talk about the major roadblocks, which are the social determinants of health, or socio-economic determinants of health. Overall improvement of outcomes for the vast number of people with type 2 diabetes and CVD is not only dependent on long-term personal lifestyle modification, but it's also determined by the social environment we are born into, including the built environment, the pollution, the noise, and the socio-economic status. Although circumstances may change over time, social constructivist theory notes that when we are bound by our environment, our situation, and the network of people who influence our behavior. The global and growing epidemic of type 2 diabetes is vast, placing an enormous burden on individuals and on society. And the magnitude of this disease continues to grow, with the global cost estimated to $1.3 trillion, and it should double by 2030 to $2.2 trillion. Access to quality housing, healthy food, green spaces, air pollution have all been directly linked to higher incidence of diabetes and CVD complication. Therefore, it is clear that tailored intervention at an individual level are not enough to dramatically reduce the burden of this disease on the overall economy, health systems, and the individual heartfelt burden of patients and family. Finally, behind every statistic, there is a personal journey, and each patient's story is a challenge too often caused by many of the roadblocks that were presented, including in this ideal pathway of care. WHF has put this story and this ideal path care on a roadmap, which is a document, and I can put the link in the chat if you want, which is really aimed at helping all members at the national country to identify what are the roadblocks specific to their countries and what are the solutions. And clearly the roadblocks, as I said, are different based on the culture, on geography, on the economic status, and the solution might be tailored and different. So we were pleased to have launched this document last year to help national societies and members to discuss at the national level with their policymakers what improvement can be made. Finally, I'd like to come back to this very interesting project that we are embarking to address some of the roadblocks we've discussed, in particular in the context of COVID. As we know, patients suffering from diabetes and CVD are much more vulnerable to COVID. But as important, COVID had an impact on awareness programs, on screening, on diagnostic and management. And because of our unique relationship with WHO, we built on the new WHO Compact on Diabetes that will be launched on World Heart Day on the 14th of November. Finally, I would like to finish with a quote from a patient from Nebraska. He says, "Changing your lifestyle is huge. It means changing everything that you do and incorporating it daily. I'm an emotional eater, sorry. So when I'm stressed, I eat. There is no support system to help you overcome this. Educating yourself is the most important thing. I know I must manage my lifestyle, which has had a direct impact on my blood pressure, reducing weight, and I feel healthier. There is no easy way to fix diabetes. It takes time and energy and effort."